Welcome to the Real Integrative Medicine Podcast. I'm Dr. Jordan Robertson, and I'm here to bring you the tools, insights, and strategies to take your health to the next level while using evidence-based integrative medicine. What's real? This is what we want to explore together. Research is ever-changing and not easy to interpret. We're bringing you the best that integrative medicine has to offer while sticking to the facts. Our mission is to elevate the practice of integrative medicine for clinicians and patients alike. Preventative solutions, nutrition, exercise, and sometimes supplements have a seat at the table in medicine, but only if we uncover real science-backed solutions. It's time to uncover what works and challenge what doesn't. Let's unlock your full health potential with an integrated approach. Ready to learn what's real? Let's dive in. All right, welcome to another episode of Real Integrative Medicine. I am Dr. Jordan Robertson. I have one of my favorite people on the show today. I am so grateful for her knowledge, expertise, and just like relentless pursuit of educating people on cardiovascular medicine and how integrative medicine and conventional medicine need to be used together in order to get the best patient outcomes. So welcome, Dr. Alex Verge, to the show today.
Hi, thank you. I'm so thrilled to be here and in more than one iteration of your podcast. So this is exciting.
And Alex and I work together a lot. Like, I actually felt like, you know, when your like mother says your full name and it's like you're in trouble, right? It's like, and Dr. Alex Verge, please come forward. That's how I felt when I was saying it. We work together a lot. Alex has been really instrumental in teaching all of our clinicians at the Confident Clinician. She's probably impacted at this point over 1,000. Actually, I'm going to probably say it's more than 2,000 practitioners in bettering their understanding and education of cardiovascular medicine over the last couple of years in our organization and outside of that. Alex, you've spoken a lot in the last couple of years.
Yeah, last year in particular was a big year for me getting out there. So I can't remember how many hours. In fact, I have a post coming out outlining some of those stats because I was a bit taken aback myself. But definitely within my goal of improving sort of our know-how as integrative practitioners around cardiovascular care, that was a big goal of mine. And so last year there were many speaking engagements, which was such a privilege, and so thrilled to be able to connect with as many people as possible and a confident clinician population and beyond. So thank you.
Yeah, it's like the Alex Verge Wrapped, and it's like you made 2 billion slides in 2024.
It was a lot. Maybe not 2 billion, but it was a lot. Yeah.
Lipoprotein, little a, 9,000 times. And that's what I wanted us to focus on.
Yes.
It's kind of, it's like new, cutting edge. I mean, I think we've been talking about it internally for a long time, this particular blood test, and we're going to teach you today why it's incredibly important that you get it done, but also give it some context, because sometimes when we have new screening tools, it can be scary, and maybe misinformation floats around, and so we certainly want to nip that in the bud as well. But really, we wanted to focus on this, I'll say new in air quotes, cardiovascular marker. But Alex, can you tell us a little bit about your backstory and how you came to being such an advocate in this space, so that our audience can kind of hear your personal connection to this topic?
Yeah, sure. And I think it's not an uncommon story. It's a combination of interests that developed over time. I've been in practice for over 20 years, and particularly in my community, lots of naturopathic doctors, especially in the past, who were focused on perinatal and postpartum and pediatrics. And I found myself really serving an older population. And with that comes, of course, more discussions around things like diabetes and cardiovascular care and healthy aging. And because I was sort of the person in town, it just kind of grew from there. And I love looking at lab work and the detective work that involves, and cardiovascular health, particularly around cholesterol and monitoring things like blood pressure. Sort of enthusiasm for tracking and prevention and monitoring really bears fruit in that particular area. And then when you couple that with, have a family history of cardiovascular disease, like lots of people, but it's been a point of discussion, some premature stuff in the past and, question marks, just even growing up, what does that mean to the family? What does that mean for me? And that having that in the background adds an extra level of interest, I think, as practitioners. And many people have that sort of story when they talk about why they ended up in the topic that they're particularly interested in. So yeah, a combination of things. And then once I really, really got my feet into it a number of years ago, it really drew me in a way that I can't explain. So yes, I have a lot of enthusiasm for the topic.
Yeah, and I'm so grateful for that. I think that for me, I've always been interested in where does integrative medicine find the between the lines for supporting people in the context of conventional care, right? Like there are certain things that integrative medicine shouldn't touch with a 10-foot pole.
Yeah.
Despite what TikTok says. And then, right, there's things where even if we follow standard care to a T, we're left with still some untapped opportunity for patients to individualize their care, or maybe we've learned something where a particular subgroup benefits from veering away from standard care just a hair so that we actually get better outcomes in them. And that's where integrative medicine does this most beautiful job, and it's really well highlighted in that cardiometabolic population. That's where, if we can look at things like family history and gender and what have you, we can get a really cool way of supporting a patient even better than what standard of care offers. But I'd love to hear your perspective on that.
Mm-hmm. Yeah, and what always comes to mind with that question in particular is whenever you listen to preventive cardiologists speak. So, I think when most people think about, say, cardiologists, what they're actually imagining are interventional cardiologists. So people who are doing the surgeries, or, you go and see them for a few minutes to talk about your heart attack that you had in the past. And there's a really specific vibe, for lack of a better term, associated with that. But there's a subsection, particularly down in the US, and not that cardiologists in Canada aren't interested in that, but there's a real line, I think, in the sand. And when you listen to preventive cardiologists talk, they will often say that they got into the preventive side of their field because they came to understand just how crucial all the things like lifestyle and those prevention-oriented pieces are, and how if someone, for their best cardiovascular health, could focus in one area, that would be the thing that would pay off the most. And it's of course, what we do so well and what we're so skilled in and what we have the time to do with people, and to think that is considered so foundational when you ask those experts, and they wish more of that was done. And here we are in a position to do that, let alone bringing more to the table for people who are going through interventions for their heart health. It's just the capacity to help people in this outsized problem in globally. We have such potential, and so it's we can do so much more, and that's why I really want to push that with the lecturing and the education, and make it accessible both to practitioners and also making my patients and all patients and clients and people who are interested in heart health out there realize that there's so much to be done at different stages along the way.
Yeah, I fully agree. And it's funny, while you were saying that, sometimes in medicine we can say, well, patients know what they need to do, right? Patients the education isn't quite as important as, we maybe imagine. Some of the biggest red flags in health, people kind of know, right? Maybe to avoid, or maybe that they know they need to eat well and exercise. But there are nuances in the discussion on cardiovascular prevention that I think even maybe the average person isn't aware of. And despite the fact that we've tried to improve knowledge for especially that perimenopausal and menopausal population, they didn't even know maybe 5-10 years ago that heart disease was their greatest health risk of their lifetime. And maybe I think that's better. There's still so much room for education actually on this topic. It's not like everyone's walking around with all the knowledge and just can't execute on it. Mm-hmm. We're actually walking around with not as much knowledge as maybe we'd like people to have.
Yeah. Yeah, absolutely. And I think that when you are having difficulty, you may have some interest or you may have heard something, but it's hard to find trusted information. And when you're reaching out to different healthcare providers, if you only have a short amount of time to cover a lot of territory, well, obviously the priorities are touched on and not those other pieces, including the questions around risk, even sort of down the road. And you're absolutely right. Sometimes I really try and be aware of being stuck in that like echo chamber of, well, I know all of these things and these risk factors. Everyone else must know about them, and we're trying to find a way for them to implement those. When I'll start with a really basic question around, is this something that you've had, say, in your reproductive history? Like, did you have gestational diabetes, for example, 20 years ago? And they'll say yes, and I'll say, well, this is why this is important in the larger context of today, 20 years later, and they'll have no idea. And so trying to be really mindful that you're absolutely right. People often don't have the information, and it's not that they don't want it or they wouldn't want to do anything with it. It's that they just don't have it and don't know where to find it. And it sort of happens by accident. And so, yeah, we just keep, it's going to be dramatic, but like fighting the good fight to get that information out there for people to be able to take that and run with it.
Yeah, so let's talk about testing, because I think in cardiovascular medicine, we have these amazing opportunities for assessment and for tracking change over time. We're so many medical conditions, that we're talking yes, no, right? There's lots of light switches. Do you have strep throat or no, right? It's this like dichotomous or, yes, no kind of option. Whereas when we talk about cardiovascular medicine, we're often looking at like trends over time, and we're looking at thresholds, and those thresholds are not, set in stone. And I think that actually creates quite a bit of confusion about the importance of cardiovascular testing, how often people should go. And I know I don't want to spend the whole time talking just about basic cholesterol assessment, but can we just step back for 1 second and say, where do we live in this moment around the value of ongoing cardiovascular assessment or screening for cardiovascular disease, like through cholesterol testing, etc.?
Yeah, absolutely. And particularly with cholesterol testing, because it is the one that is often most confusing or frustrating for people when you start having the conversation. And it is a good segue to the lipoprotein little a conversation, because there's a sense that this is a binary piece as well. Either it's high or it's not high, and that's what you need to know, when in fact it's a relationship that the risk goes up as the number goes up. But so the nuance of that has changed over time as well. But if I backtrack particularly to the cholesterol conversation, understanding that it's a risk factor. Having high cholesterol is not a disease in and of itself. It is a risk factor for cardiovascular disease in the future. And we will talk about cholesterol as being sort of the necessary and sufficient ingredient for the development of atherosclerosis, which means we need elevations in cholesterol to contribute to plaque formation, and that plaque progression increases the risk of developing the outcomes that we're trying to avoid, like a stroke or a heart attack, for example, among other things. The cholesterol piece, again, like you said, not binary. It's not like, oh, you have too much, or if you don't have too much, then everything is fine. It's a spectrum, and we determine, for better or for worse, I'll often explain, if the number that you fall, or the number that you've been measured at, is acceptable or not based on your overall risk. And so if your cardiovascular risk for in the future is high, we're much more worried about your cholesterol level, and will really encourage a very, very low level because you're already at great risk. But if you're determined to be on the lower end of that risk scale, then we're going to have, again, for better, for worse, and I would say for worse, but we're going to have more general flexibility with how high your cholesterol can go before we start to pay attention. And so what that can look like, if we sort of translate that, if someone's at very high risk of cardiovascular disease, such as they've already had a heart attack, let's say, they're at very high risk of a subsequent event in the future, then we're going to be looking to see their cholesterol, their LDL cholesterol in particular, ideally below 1.7, 1.8 millimoles per liter or 70 milligrams per deciliter, for example. If we contrast that with someone who's deemed to be low risk, well, we might accept a cholesterol level that's an LDL cholesterol level that is as high as 4.9 millimoles per liter or 190 milligrams per deciliter. Those are two extremely different sides of a range, right? And that acceptable number is based on someone's risk. So when someone comes into the office and they say, is my cholesterol level good? And then I have to say, well, this is a 10-minute conversation because we have to determine, what your risk level is first. And then based on guidelines, that would mean that this number is acceptable or not acceptable. But the last piece to that puzzle is that just because something is considered acceptable doesn't make it optimal or not potentially contribute to future problems. And that gets really frustrating for people. They're like, well, if someone told me it was acceptable, then I'm translating that to be, it's no problem. It's not causing me any harm. But what it means is that we've, for a variety of reasons, it's been decided that actively treating it with a medication, the cost-benefit ratio may not be worth it over a period of time. And if your risk goes up over time, then that cost-benefit ratio changes and we may advocate for more aggressive tools at that time. But of course, the frustration is a lot of people, myself included, would say, well, if I knew that it was headed in that direction, I might want to make changes, lifestyle changes in particular, at an earlier time. So by the time my risk goes up, if it goes up, that I'm not told that, well, this number is now too high and has been too high for the last 2, 5, 10 years, when you would have had an opportunity to do something about it. So yeah, the conversation about cholesterol is both frustrating, confusing, and very nuanced, as is exemplified by that long little rant.
Well, it's funny because as you're talking, and for me, I like to, always when I'm looking at some of the challenges with standard care, is look for those nuances, right? And the assumptions that we're making in order for it to be done to its best ability, right? Like on paper, that sounds amazing. In practice, there are risk factors that we would list that would make us more suspicious about someone's cardiovascular risk that are probably not being assessed on a general basis. And you even mentioned one, like pregnancy history is part of, or should be part of, that risk assessment. And yet that's probably not being done in a patient who's in their 60s, who had their kids long time ago, many lifetimes ago. And yet that technically should be part of the conversation, or helping someone understand like the nuances between maybe sex specific risk factors other than pregnancy. So the assumption there that like everything being perfect, we should put you into this like almost algorithm to decide where you live in the context of individualized medicine for cardiovascular prevention. But the reality is that actually requires something that medicine doesn't usually have to offer, which is provider time.
Yeah. And if we want to segue to the lipoprotein little a or LP little a conversation, that is really important because when we look at risk calculators, so if we go back to what I said, which is, first step is to be classified as low, intermediate, or moderate, or high risk, the calculators that do that are pretty, for the most part, basic, and that's particularly true in Canada, where we're just looking at stratifying risk based on age and sex and whether you're a smoker or not, whether you have high blood pressure or not, what your basic cholesterol level is at, and whether you have diabetes or not. Those are all very important, but they certainly don't ask the question of any of the things you've just discussed around pregnancy history, for example, or any of the other things that we've long since established are additional risk factors or enhancers, or mitigators, for example. And so things like that, or if someone has an inflammatory autoimmune condition, or if they have an elevation in lipoprotein little a, they're considered things that will add to someone's risk that is outside of that risk calculator, but you have to be able to ask about it. Maybe you have to have measured it. So the lipoprotein little a, you have to have measured that to add it to the understanding of that basic risk calculation. So if someone is considered low risk, for example, but let's say they're on the higher end of that low risk, about to tip over into intermediate risk based on a traditional risk calculator, if they have an elevation in lipoprotein little a, or if they're diagnosed with a inflammatory autoimmune condition like rheumatoid arthritis, that would be considered a risk enhancer and kind of tip them into that intermediate category. And our decisions around what best approaches would be taken will now change. But to discover that, you either have to test things or ask questions. And to your point, if we don't have the time to do that, then how does that conversation happen? And does that mean that maybe down the road people figure it out, but they could have known about this 5, 10, 15 years earlier? And that education piece is so important, because I can only imagine how challenged doctors are, primary care providers are often, to fit these things in. And if a patient can come to the table going, oh, I heard about this, what about this? Then there can really be this connection between the two who are pulling in the same direction to get the right answers for that person for their long-term well-being.
I had a really difficult postpartum experience, and I would never want another person to go through that. I'd love to invite you to the Thriving Trimesters free online summit that I'm hosting with my favorite colleagues at the Confident Clinician. This summit is intended for the public, so if you are in the family planning stage, if you're in a fertility journey, if you are in pregnancy, trimester 1, 2, or 3, or you are in the postpartum phase, this summit has something for everyone. We're talking about mindset, nutrition, exercise, supplements, pelvic floor, how to recover from your birth, and more. I'm so excited and thrilled to showcase my colleagues who have absolutely the most evidence-based strategies for supporting people in that perinatal period. We want you to feel well supported while you focus on taking care of your baby. You can register for the summit today. It starts February 24th and it's absolutely free to attend. Use the link in the show notes for you to get access to enter your email. Yeah, I'm so curious what we're going to learn in the next, 10, 20 years about cardiovascular risk factors to add to that algorithm to make those assessments. I really would love to see that evolve, right? And even if we told the average healthy walking around woman what they're screening for, she might immediately consider herself to be quite low risk, right? Do you smoke? No. Do you have high blood pressure? No. Do you have diabetes? No. And then it kind of makes it sound like you're going to come out, squeaky clean on that assessment. Right. And yet there are other things that we should be sort of checking, and many of those algorithms were developed a long time ago, where some of those pieces were maybe more prevalent in the population. I think of smoking specifically, right? So when everyone says no to smoking, or at least a whole lot less people say no than they did 40 years ago, what are we going to uncover as being the most next important question that we ask? And do we have that knowledge right now? We might. And then where is it being asked, and where is it being asked? And it's usually in these longer conversations about cardiovascular health that we start to uncover those pieces, which I think is so fascinating. I always found it crazy when I would talk to a patient and then they'd casually mention that they had a blood clot while they were on their oral contraceptive. And I'm like, whoa.
Yeah.
Right. Back it up. where back it up. Where is this, right? In your history, and does everyone on your health team know this? And it's very common that people, I always say, have lived many lives before they make it to the doctor that's serving them in their 50s and 60s. And those lives are not being told or shared about in their history taking. And yet they play a tremendous role in us understanding their risk. I find that so interesting. Mm-hmm. So yeah. Let's segue and talk about LP little a,
sure.
Which I need to credit almost 100% of my education about this particular topic to you. But can we just talk about the history of it a little bit, not to bore people, but for them to understand like why this is a novel marker in the first place, and then let's lead into like what makes it so important that you're screened.
Yeah. And at the very beginning, when you said sort of like the new thing, LP little a, and you're right, new, I would say new because there's finally, like so many things, it has to hit almost like a critical mass of information and discussion and mainstream in its own way before it really becomes the valuable discussion that it was always meant to be, I guess. And I don't know, to be fair, I don't know how long ago it was identified, but it's much longer than you might think. You know, discussions around LP little a have been around for many, many years, but this understanding of it being not just quite common as an issue, but also the significant risk factor that it can be, or risk enhancer, for using the right term, that it can be, is largely more recent thing. And again, that doesn't mean the last 6 months, that means the last 5 to 10 years. But even so, the building of that and the wholesale understanding of how to discuss it and test it and address it has been relatively recent, all things considered. So if I backtrack a little bit and just talk about what it is, if I'm trying to simplify as much as possible, I'll call it an evil LDL particle. And that's not entirely fair, and it muddies the waters a teeny tiny bit, but at its essence, that's what it's all about. So LDL particles are particles that are floating around, obviously, in the bloodstream. They carry cholesterol, much like other particles do, including HDL particles and VLDL particles and IDL particles, which we don't talk very much about. And the reason we talk about LDL particles as being bad particles, although that is a misnomer as well, is simply because the cholesterol it carries, which is the same as the cholesterol anywhere else, is carried towards tissues, including blood vessels. So those LDL particles can get trapped in the blood vessel walls, can deposit the cholesterol that they carry. There's inflammation that comes as a result, and then we start to see plaque developing and plaque progression. In contrast to HDL particles that will take things away, which is a good thing, all things being equal. That's why we have this initial conversation around LDL particles are bad, or LDL cholesterol is bad, and HDL cholesterol is good, because one is bringing it to the site of the problem and one is taking it away. Now, there's a lot more nuance to that, but I wanted to start there because if we talk about how LDL particles aren't inherently bad, they're just doing a thing, if they get into that blood vessel wall and then leave again, no harm, no foul, basically. But the more of them we have, as exemplified by your LDL cholesterol being high on your panel, the more likely it's going to get into trouble by going into that area and depositing. The lipoprotein little a is a type of LDL particle that has an extra little, I'm going to call it a tail, or an extra little protein on it, which makes it inherently more problematic. And so that extra little tail, which is where that little a comes from. So the little a stands for apolipoprotein little a, as opposed to a big A, which is something else. So that's how they differentiate it. And every once in a while now, on podcasts or whatever, I'll hear people just say lipoprotein A. But really the tradition is calling it lipoprotein little a because of its extra protein, this apolipoprotein little a, that adds this extra curlicue to an LDL particle. And that extra little curlicue is what causes the problem. It promotes inflammation, it promotes more atherosclerotic progression, so that plaque progression is more likely to happen. It also has what's called a prothrombotic impact, so it can increase blood clotting. And so this LP little a particle, like I said, is like an evil LDL particle. That's why I sort of qualify it that way. About 20% of the population, through genetic reasons only, have higher amounts than the other 4/5 of the population. So most people have very little LP little a versions of LDL cholesterol or particles, but about 20% of us have a greater amount. And that's just completely genetically induced. That's just bad luck, frankly. So if you have more of these, because they promote inflammation, they promote atherogenic, or they promote atherogenesis, or more plaque formation and progression, and they promote thrombosis or clotting type of activity, you can see how that increases cardiovascular risk over time. And we've been able to measure it, but again, that hasn't certainly been something that was done regularly, and there was some confusion as to how to best measure lipoprotein little a. So again, over the last 5 to 10 years, that's been further elucidated. So if I have to summarize a couple of different things about it, now that we know what it's all about, I would say that the measuring of it is now considered, as of 2024, it's now considered a thing that's important to do for everyone in an effort to better understand their long-term cardiovascular risk. Canada's said so since 2020. The US has now been on board as of 2024, largely. So the National Lipid Association put out a big statement last year saying the evidence really is kind of overwhelming at this point. We know, or the evidence supports, that people with elevations in Lp(a), again, through no fault of their own, unfortunately do have an increased risk of heart attacks or MIs over time. And they also have an increased risk of aortic stenosis due to calcification. So aortic stenosis is one of our heart valves. It's the valve that is the last valve leaving the heart, that big vessel, the aorta that's leaving the heart to shunt all the blood to the system. The last valve leaving the heart is the aortic valve. It can become calcified and stiff and not work right, and elevations in Lp(a) increases the risk of that happening. Taking a pause, increased risk does not mean it will happen. And that's a conversation I have with people so often, that these conversations can be scary for people. And we want to be very mindful of things that are increasing risk. That's why we have these conversations. However, having something that increases your risk is not a crystal ball saying this is going to happen to you. It just means compared to people who aren't in that situation, you are a little more likely, or a lot, depending on the situation, more likely to develop that in the future. But we want to set you up for future success, which is why we're having these conversations, so that doesn't become the case. But I don't want people, if you're sitting there going, oh gosh, I just found out I have an elevation in Lp(a), I don't want you to think that that means you're going to have a heart attack in the future. But as we're going to talk, I'm sure, in a few minutes, what it means is there is some benefit in being more proactive around your heart health as a result of this risk enhancing factor. The last piece I want to add here before we get into some other aspects of that conversation is that the measurement piece. So I always feel like it's like a battle to figure out what's the best way to measure something. And there are two ways to measure Lp(a), and it's finally really been solidly determined that there's a better way and a worse way. And the reason for that is because that little protein, that little tail I was talking about that goes on to the LDL particles, this little lipoprotein little a, can actually be different sizes. So it's like, there's short people and there are tall people. It's sort of the same thing. So our apolipoprotein little a, apolipoprotein little a, can be short, it can be longer. And we never know for any given particle if it's a shorter version or a longer version. And that can matter when you're measuring things, because if you're just measuring like, what is the big bucket worth, then we're like mushing it all together, as opposed to saying, well, how many do we have, shorts and talls? It's a weird way to put it. So the way that it's typically measured everywhere but the US has been nanomoles per liter, millimoles per liter, nanomoles per liter. And that is the preferred way of testing Lp(a). In the US, until quite recently, and still now mostly, it's measured in milligrams per deciliter. those numbers are very, very different. So if you go, oh, I had my LP little a measured and I'm eager to hear what kind of numbers you're about to spit out, you really need to know if it was measured as nanomoles per liter or as milligrams per deciliter, because they are different ways of measuring it and there is no way to convert between the two. And so every once in a while, someone will say, oh, I had mine measured, it's totally fine. It was a 50. And you've just told me that 100 is the number we're looking for, 125 is the number we're looking for. I'm like, so good. And then we delve a little deeper, and what they're talking about is a 50 milligrams per deciliter, which is actually considered high risk from that US measurement perspective. But in other units, that nanomole per liter, 50 is considered on the low end. So that's an important distinction. And the more we move forward, you will only see nanomoles per liter. You will still see milligrams per deciliter for now, but because it doesn't give us the accuracy and the best understanding, even those are moving towards the nanomole per liter, and everywhere else nanomoles per liter is now being commonly used, such as in Canada, for example. The numbers, since we're interested in that before we move on. So the numbers, it used to feel like it was more of a binary piece. So we started the conversation earlier around how so many things feel like, well, it's either like positive or like it's a problem or it's just not a problem. And that used to be kind of the language with LP little a, whereas it's either high or it's fine. And like I said, about 20% of people are going to have higher than the bulk of the population. But even within that, what we've determined is the risk kind of goes like this. So even if someone falls into that lower risk category, so in Canada, we're going to say like 100 nanomoles per liter is it used to be 125, but let's say 100, line in the sand, nanomoles per liter. Anything below that is fine. Anything above that is high. But if you've got someone at 90 versus someone at 7, that person at 90 is technically at greater risk than the person at 7. But all of the people under 100 are considered that like 4/5 of the population who have a like normal amount. It's once you crest over 100 that you're going to be considered in that 20% of people who have a higher amount. And certainly the higher you go, the theoretically higher your risk. In the milligrams per deciliter, under 30 is considered low risk. 30 to 50 is considered sort of intermediate. They have more of an intermediate zone in their descriptions. And then above 50 is considered high risk. Remembering there's no conversion. So there's no way to say, well, I've heard that this other way is better of measuring it. What does my 45 milligrams per deciliter mean in terms of nanomoles per liter? We have no way of doing that. But we've got these general classifications. I'm going to stop there for a second. I feel like I'm talking a mile a minute with lots of information.
No, this
what
is
do you
great.
Think about
this
that,
is really
Jordan?
helpful. This is really helpful. And I'm glad that you said, when we learn something new in science, right, we don't always get it perfectly right the first time. And sometimes we'll swing pendulums like in the wrong direction, right, where we test everybody, we biopsy everybody, and then we learn from those, that new population data. And often over a few years, things start to sort of fall in the middle. And what we have to remember is that what we're trying to do is use your lab work to be a crystal ball a little bit, or at least help us understand like your future risk, which is not easy. And because, you're so much more than your lab work, but what we want to do is use it as a really great conversation starter, because especially in cardiovascular disease, like if we said, your risk of this super rare disease is increased by, 300%, but like your actual risk at baseline was 0.0000001% of the population struggles with this, even a 300% increase is really not going to change your life that dramatically. But when we're talking cardiovascular disease, this was already our number one risk factor and risk for lifespan and health span. And so when we get increases, or when we can reliably predict increases, the numbers we're talking about are actually relatively important. But I would love if you could touch on that, Alex. Like, what is like that magnitude of increased risk that we see in that upper 20% versus the bottom. I love that you call it the upper 20% and the bottom 4/5.
I know.
Like you go from like the percentages to the fractions, and you're making us come with you.
I figure yeah.
But we've got the top 20%, and I'm just going to say the bottom 80%.
Fair enough.
But what is the risk differentiation between those two groups? Like, how much more risk is it? Like, can we quantify it?
Yeah, and I would say that this is something that's definitely more recent in its exploration. And I think that's one of the reasons, in particular, the US was waiting to get more information. And by the US, I don't mean like it's a collective, but the different organizations, right? The American College of Cardiology, the National Lipid Association, there are a number of organizations. Sometimes they work together, sometimes they don't. So, but all things being equal, they were really looking to see how the data built so that the quantification of that risk could feel big enough and clear enough that the call for universal testing made sense. So universal testing being every adult should have this done. Every adult should have this done probably only once. There's maybe some exceptions to that, but the reason it's recommended only once is because it is largely genetically informed. And so if you're high at 12 years old, you're going to be high at 45 years old. It doesn't change our understanding of the situation. The data is strongest for heart attack risk and that calcification, that aortic stenosis risk that I was talking about, which can contribute to other problems long term. We have other associated risks. And because it's actually a log linear, but because it's this linear relationship, the higher you go with your Lp(a), it's really hard to be able to figure out quantifying that risk, right? But we can look at 10% increases at that sort of lower level of high in that top 20%, let's say. But that number goes up as your Lp(a) goes up. So an Lp(a) of 500 is going to be significantly risk enhancing compared to that 125, let's say, if we're talking about nanomoles per liter, and probably starting around a 10% increase in MI at that lowest level. And it's harder to really pin down the increased risk at those higher levels because, of course, there are fewer and fewer people with those higher numbers. So when you're investigating things like this, if there's only, maybe not a handful, but when there's very few people who have an Lp(a) of 800 nanomoles per liter, it's hard to glean what the increased risk is because we have so few people to study, for example. I know that's a very roundabout conversation to say, in some ways, we're not fully sure what that increase looks like. And it depends on so many factors, including where you are on that Lp(a) list or like threshold or range, and what your pre-existing risk was, right? So if you think about what Lp(a) does in terms of promoting progression of atherosclerosis, promoting inflammation, promoting thrombosis, if you already have some of those issues occurring, the risk is certainly going to be enhanced compared to someone who doesn't have those issues going on, which is why when we talk about treating these things, we are trying to create a baseline that is as non-problematic as possible, because if we layer that on top, if there's nothing there to cause any issue, then this is going to have less power over the situation. Did that help?
Yeah, it does help. It does help. And it's interesting. It makes me think of so many things. Like universal screening is such a unique scenario when we talk about like evidence-based practices and evidence-based medicine. And many times patients can feel quite frustrated that tests are not offered, to everyone, or that they feel like they need to fit a particular criteria to qualify for a test. And that's with good reason, right? We don't just MRI everybody once a year because we would find things we don't need to find. We would find things we don't want to find. We would find things that were meaningless, but we would make them meaningful, and maybe that would increase your risk of like biopsies and surgeries and things that you didn't need. And so there's reasons why we don't universally screen all people for all things at all times. And, if you're a very health conscious person and you're like, I want the best of the best, it's easy to slip into that sort of like belief trap that means testing everything all the time and trying to stay on top of things through testing. Whereas this, like, we've actually like jumped over a couple of, what I would maybe consider like universal screening rules where we want to be so darn sure before we jump over here. And you can correct me if I'm wrong, Alex, if you're like, no, Jordan, like the research has caught up. We are so darn sure. But we almost we want to catch people, not just because we can, but also because we have an answer, right? That like our willingness to say, you know what, let's just test everybody has partly come from the fact that we know that earlier intervention and earlier support and solutions for cardiovascular disease always has a better outcome, right? Where my MRI example, that would like more often than not lead to a worse off scenario. Whereas if we could flag even some people earlier with cardiovascular disease, as a general population, we would be doing much better, and we would be saving lives if we did that, because we have a safe, accessible, reliable, effective, cheap solution if people do have increased cardiovascular risk. But I mean, what do you think about that? Like, based on what I just said there, like what does that make you think of?
Yeah, it makes me think of two things. I think the additional urgency or the additional interest in universal screening as it relates specifically to Lp(a) is that because of its genetic nature, that if you find someone with elevations in Lp(a) right now when universal screening hasn't really kicked in that well, really, we're mandated to do cascade screening, which means that if I've encouraged someone or they've already had their Lp(a) done, it's flagged as high, the next part of the conversation, or at least a part of the conversation, is if you have children, they should be screened. Those are especially the people that we're looking to support, because if they're also seeing elevations in their little Lp(a) and they're at 14 years old or 9 years old or whatever, even if they're 25 years old, they have a much greater runway to mitigate that factor and end up largely unaffected potentially by that. And there's a lot of interest in that population health aspect of universal screening for something like Lp(a). So it's not just the person sitting in front of us, it's also their children, their siblings, their parents, depending on their age. It can all of a sudden, one piece of information can impact a whole heck of a number of people in a really positive way. So that's the first piece that I think is really important, and something that is often forgotten. I mean, I'll often be the first person, even with people who have been identified as elevations in Lp(a), the first to say or ask, do you have children? Has anyone else in your family been asked to do this test? And if not, the answer is they should, because they need to know their status as well. And then the second piece, and I think probably the point you were going for, is that, or at least in part, was when we do have universal screening, the idea that we've got a really great solution, right? We find you've got a problem. Aren't we lucky? We have a solution. That's why we're trying to figure that out, because we can fix it, whatever that means. And then everyone's good, right? From a individual health perspective and a population health perspective, especially in a socialized healthcare setting, we've done good by everyone, right? And the trick with Lp(a) is that we don't currently, although I've got something to say about what that looks like down the pipeline, we don't currently have a treatment for Lp(a). And that provides a lot of anxiety and very understandable frustration for people who have been flagged as high. Because typically it's not people going to their doctor saying, I want to be, tested for Lp(a). It's a healthcare provider who said, we should do this because it's part of universal screening, or I've learned more about this recently, so we should do this. And then the patient gets told that they're high and they're like, okay, shoot, what are we going to do about it? What do I have to do? What medication, what what am I going to do to treat my high LP little a? And the answer is, well, we're going to do other things, but we don't have something to treat your high LP little a. And people get mad and anxious because now they've been told they have this extra risk that they're living with, but no solution to that. And to your point, do we try and test people for things we can't deal with? Not typically. That's not that helpful. If we're not going to change how we're approaching something, testing, there's big question marks with that. But I would posit, or I would challenge that we do something with that information. But what we do is not currently treating the LP little a directly. We work around it to mitigate the risk, the extra risk that brings. And I think that's the larger part of the conversation. But if I actually start with there are medications that will reduce LP little a. There are at least 4. 2 of them have gone through the studies to show that they very significantly reduce the LP little a, and they are currently finishing the aspect of the study that looks at outcomes. And so we've often talked about this, where there's a very big difference between what a medication can do to the thing and does it have an impact on what we're really interested in, right? So if something reduces cholesterol but doesn't reduce the risk of you dying of a heart attack, do we really care, right? We want to not die of a heart attack. We don't really care about the number. It's the outcome we're trying to prevent. If we increase bone density, but we don't reduce the risk of fractures or any of those outcomes, is that the helpful tool we were hoping for? Those sort of questions exist a lot in the work that we do. And so for LP little a, the 2 medications that have been very clearly shown to reduce LP little a very successfully, 90% successfully, are coming to the end of their outcome studies in terms of, do they reduce the risk of cardiovascular disease like heart attacks? And so one of the studies is due to come out, be published this year or be finished this year, and one is due for next year. There are a couple more that are in the pipeline of the initial investigation, so that's more like 2027, 2028, 2029. We're not worrying about those. But these 2, 2025, 2026, there's a lot of breath holding and enthusiasm and angst around, is that going to tell us what we want to know, so that there is a medication out there, or medications out there, to address this in particularly high-risk individuals. But setting that aside, because those things aren't available right now, and even when they becoming available technically and becoming available practically are often 2 different things. The fact is, for anyone who's been told that they're high in LP little a right now, that's not a solution. And so we talk about reducing all of the other things, or doubling down on all of the other things that will increase cardiovascular risk. So if you've got, these things that are increasing your cardiovascular risk, and then you learn that LP little a could be something that increases your cardiovascular risk, and you do nothing, then they're all increasing your cardiovascular risk. If we can't change the LP little a, but we can reduce the risk being provided by these things that are what we call modifiable, that we can change, then your overall risk comes down, even if the LP little a number hasn't changed. So that is actually often disappointing to people, but incredibly meaningful. And it allows us to, we have lots of things we can look at. We can be more aggressive and more mindful and more careful around a regular cholesterol, or LDL cholesterol numbers, our blood pressure, our nutrition, our movement, our blood sugar. If someone is smoking, then we are really, really, really spending time on smoking cessation. Our sleep, which can have an impact on cardiovascular health. We can ask those questions about other aspects of prior risk so that we better understand what's going on. Some of that is medication. A lot of that is lifestyle. And again, that's where we really shine. And it's the conversations that I am most enthusiastic about with the people in their 20s and 30s who are now being flagged with high LP little a.
So, I mean, I hope that people feel inspired in hearing that, right? It's interesting. The women in my family have just been flagged with elevated LP little a. And I loved listening to your story, like you share first before I did, because what was great was that when my one family member tested high, their provider said, you need to tell, any of your other blood relatives that are, still living, which I'm like super happy with. And then my mom was like, I have to tell you something, someone in the family. And I was like, she's like, what is this? And I was so, I was hopeful that it came to me before me saying, hey, I think you should have this done. I think that was really great. But now it's put it on my to-do list.
Yeah.
And so hopefully it doesn't sit on a requisition for a year, because at 43, this would be a really lovely thing to know. Whereas my family members are finding out in their like 60s and 70s, right? So I think that that's really, really great. But hopefully it feels inspiring. And you're right, like testing something that we don't have an immediate solution for, or makes people feel like something's written in their genetics, that can be quite triggering, right? If we think about, why don't we do widespread cancer-related genetic screening for people? It's because the benefit doesn't always outweigh the risk of feeling stressed or afraid after having those tests done. And they are not like this living will that this is what's going to happen to you. You actually, so you need to really quite reflect on some of those other screening, options. How is that going to land with you if you learn that you have increased genetics for something? As a total sidebar, I did my 23andMe a few years ago, and I have like the increased genetics for dementia, and with like the lipoprotein, the ApoE, I should say. And I also have the increased risk of bipolar, which, because I've struggled with PMS and PMDD, I immediately was like, have I been misdiagnosed this whole time? Which of course is not the case. But it's weird to get your genetics, right? It makes you feel weird about your health status and health future when someone sends you a report and it's like, well, here's what might happen to you. So I can see why it can be frustrating for people to do that assessment, and then they're like, well, what do we do about it? And the answer right now is like, well, nothing, or keep doing what you're doing, right? Like that never feels great. But remembering that we're using it as part of your total risk assessment in this moment, and pairing it with all of those other things to help us understand, like we said at the beginning, your cholesterol is on a spectrum of risk, and we're adding it to the list of things that make us feel like you are more or less risky than the average person. And that's going to help us make decisions about when we do interventional cardiovascular support versus just preventative. And that it's just another piece of the puzzle. And we should, I hope that people feel grateful and like it's an opportunity to have that window into their cholesterol, where in the past, it's, we go, maybe hopefully you have your screening cholesterol done as it's recommended to you, but this is giving that like additional layer that helps contextualize your results a little bit better than we've had the chance to in the past. So what's your advice, Alex? Like going forward, like what would you hope that our listeners take away from this episode? I'd also love if you could share how listeners could find you also, so that they can learn more from you.
And just one little addition to what you were saying, I would say that there are some people who are happy to hear the information sometimes, and that's a very strange way to put it. But in a family where there's been a history of premature heart disease with no explanation, and so someone will say, my grandfather, his father, his uncle, my whatever, like it, you can see it coming down the family, and they'll say, they weren't smokers, and their cholesterol they always said it was fine. And then when they discover that the Lp(a) was elevated, that can actually explain a link between premature cardiovascular disease over the years. And so if someone's cholesterol level is normal, that doesn't eliminate the possibility of elevations in Lp(a). And by cholesterol being normal, I mean, that's within that, again, context, right? Yeah. But sometimes people are like, oh my gosh, that explains so much. And it was like this mysterious thing that no one could figure out. And now I'm glad to know about that. And so sometimes that information isn't the discouraging news it might be for someone else. So I would also just add that to the list. And I would also say, and this is probably the big takeaway, that when someone gets that information, I rarely frame it as there's nothing we can do or there's nothing we will do. Because even in that 25-year-old who's generally like a 25-year-old, unless there's something very unusual going on, is at very low cardiovascular risk, just inherently, because it takes a long time for cardiovascular disease to develop. It's a decades-long experience. And so we could say, and I will see this, sometimes I'll have to have a conversation around, I realize your other healthcare provider may have said this means that we will have to look at this again in the future, and you'll probably have to go on statins earlier than someone else might have. But that's like tomorrow's problem. Whereas I will say that may be part of your future, but there are things we can do today. And I think that's the takeaway, that it's important to get that tested, because I genuinely feel it gives a piece of information that more completely allows for protecting future you. And it allows us to find ways to support your cardiovascular health today, and in an ongoing way that, and this is my old refrain, that are sustainable, but that make a difference. It's like compound interest, like little changes now, especially if you're motivated by an elevation in Lp(a), pay such dividends over time that it's so worthwhile to do those things and not wait until, risk has escalated enough that then you have to pick out or pull out bigger guns. Maybe those medications are going to be required, and they often are, but that doesn't mean all of those other pieces don't significantly contribute to lowered cardiovascular risk, because they absolutely will. And even in scenarios where we 100% need medication on board, I'm thinking, let's say, people with another genetic condition called familial hypercholesterolemia, those people require medication for their best health. The people who also do lifestyle things see even better results, right? And I think sometimes it's presented as like an either or you do this so you don't have to do that. And in fact, in these scenarios, adding those changes and finding a way to incorporate changes that are going to be helpful today, and you'll feel better for them today, but also set you up for success tomorrow is the goal. And I actually get really enthusiastic about being given that opportunity, and sometimes with a little bit more buy-in or incentive with the person, because they're like, oh, there's this thing that is here that I realize now is potentially going to be an issue, and I'm more invested in making some changes now.
That's great. That's so much more positive than what I said. So I appreciate you like reframing that, because I think you're right. Like that knowledge is power, especially for, that quote unquote motivated individual, right? Who's looking for every advantage. And that little bit more information just gives you more, maybe motivation. And I'm curious, and I'm sure that those will be studies in the future, right? Where we look at behavior change and people who are, lipoprotein (a) aware versus not aware, and how it influences the way we show up for ourselves in our health. But generally, the more that people know, the better they can do for themselves, because it's easier to prioritize. How can our listeners find you, Alex?
Oh, right. Although every once in a while it feels a bit haphazard, Instagram's probably the best place right now. I have a very education-focused feed, so I'm trying to make sure that these pieces of information get out there. I would say that's the biggest piece. I do have a blood pressure course coming out in the near future, so I'm excited to share that for the general public, but stay tuned for that.
Amazing. Thank you so much for sharing with this audience. I feel like this is the perfect topic. I love seeing this come to the forefront in Canada and the US over the last couple of years, and I think this is going to make a big difference for all of our listeners, so I really appreciate you.
Oh, thank you for inviting me. As you know, I have lots to say about all of this, so I'm always happy to share.
That's it for today's episode of the Real Integrative Medicine Podcast. I hope you're feeling inspired, informed, and ready to make changes that truly support your health. If you found value in today's discussion, don't forget to hit subscribe, share this episode with someone who needs it, and leave a review. It helps us reach even more listeners just like you. Your health journey is personal and it's powerful. Let's keep building on the knowledge to give you the confidence you need to thrive. It's important to remember that the Real Integrative Medicine Podcast is for educational purposes only. Be sure to talk to your doctor before making any personal health changes. This podcast isn't intended to diagnose you, and no doctor-patient relationship was formed by listening. We'll see you next week.